Welcome to this dedicated webinar to RH, Prevention of Stillbirths from RH Sensitization. And I request our President, Prof. Neelam Aggarwal, to please welcome you all.
Yeah, good evening, everyone. I welcome all our esteemed speakers, chairpersons, all the delegates, all delegates present online. Welcome, everybody. So today's webinar is very important. In fact, the proverb prevention is better than cure is very appropriate for today's seminar, because we need to sensitize all general doctors, obstetricians, everybody about Rh Isoimmunization. So to be very careful about the blood group and anti-D prophylaxis and anti-D after the delivery, after abortion, after IUFT, after any bout of bleeding during pregnancy. So this is very important aspect, so that there is no problem of isoimmunization. So we have very good speakers, very experienced ones today. So without taking much time, I'll just hand over to Dr. Tamkin for the further proceedings.
Oh, thank you so much. So as the Secretary of the Stillbirth Society of India, I have the privilege of introducing the Committee of Prevention of Stillbirths from RH Sensitization. And I'm really fortunate, the team, SBSI is really fortunate to have none other than Professor Mandakini Pradhan, who's a DM in genetics, who established the fetal medicine department at SGPGI, prestigious SGPGI, Lucknow. And she's the chairperson of our committee, a very dedicated clinician. She's currently the chairperson in Genetics and Fetal Medicine Committee, FOXY. We have all attended the series of webinars which she has conducted as the chairperson. She's professor and head currently. And this is the slide she sent to us. So she said, publications few, book chapters countable. And her aim is to establish maternal and fetal medicine in India, which is she's doing very nicely. As the secretary of the committee, we have Dr. Naini Tandon, who's who's a private practitioner, consultant obstetrician and gynecologist with special interest in high-risk pregnancy, infertility, and PCOS. She's the vice president of Lucknow Menopause Society, ex-secretary and treasurer. Lucknow Menopause Society received the Best Paper Award and delivered many lectures at various state and national level conferences, and has great experience as publisher, as editor of several newsletters and in papers in scientific publications. So I will now stop sharing and hand over the proceedings to Dr. Mandakini, the chair of the committee.
Thank you, ma'am, for those excellent beginning. And giving us a chance to have a committee which is dedicated to Rh isoimmunization. That is 5% of our pregnant patients are Rh negative. And then as an obstetrician, we have got privilege to look after them and probably prevent this isoimmunization. So rightly said by Dr. Neelam that it is a preventable condition, if not then a treatable condition almost. So I have got the privilege to introduce Dr. Vatsala Dhadwal, who will be the chairing the whole talk. And I'm thankful to Dr. Naini Tandon, who is the secretary of this committee, and almost she has done everything. As you have joined, I also similarly have joined like that. So it is the work of Dr. Naini only. I have got this privilege to introduce Dr. Vatsala, who does lots and lots of work on fetal medicine. She is currently professor and head of the division of fetal medicine at All India Institute of Medical Sciences, New Delhi. And they are the pioneer in establishing fetal medicine division in their department. She is executive committee member of Society of Fetal Medicine from 2014 to 2018. Then chairperson of AOGD of Fetal Medicine Subcommittee. So, and secretary of AOGD, that is Association of Obs-Gynae of Delhi. Then she has got numerous awards to her credit as a young researcher award, then Rogam Foxy Award, which is dedicated to RH negative, the protocols and the publications. And then ICMR International and Senior Biomedical Scientist Fellowship Award. The best part of it is the largest series of Rh isoimmunization and intrauterine transfusion published from India goes to their credit. So she has got more than 160 publication and number of, and you as a fetal medicine specialist, you try to attend all those lectures taken by Dr. Vatsala. And above all, she's one of our good guide, friend, and almost any helping need you want to have it, you probably sees the one who will have an expert opinion in the field of fetal medicine. So I welcome you, Dr. Vatsala, to this committee webinar, and you will be chairing the session. And I thank you for doing this job.
Thank you, Dr. Mandakini, for giving me this honor, and thank you for your kind words. Thank you so much.
So our first speaker for today is Professor Sukumar Barik. He'll be speaking on the prevention of Rh alloimmunization in pregnancy. He's the professor and head of the Eye Care Institute of Medical Sciences and Research, Haldia, West Bengal. He has 52 publications in national and international journals and 11 chapters in textbooks to his credit. Professor Barik, over to you, sir.
Good evening, and thank you very much for inviting me to these wonderful topics. And in next 12 minutes, we'll be discussing a very simple aspects, the prevention of Rh alloimmunization in pregnancy. I'm very happy that a Rh negative man will be discussing a topic on Rh alloimmunization in pregnancy. And my mother was born in 1940 when the Rh was discovered. What a pleasant surprise. And this is very important thing to remember in that way. And in my talk, basically based on this particular guideline, which is published by the FIGO very recently. And not surprising, after this discovery of 1940, then the prevention come into the picture in 1968. And then subsequently in 1984 about the antenatal immunoprophylaxis. This document is not a surprise. Or you can think that why this document has been published by the FIGO, the guidelines for preventing research disease, a call for action, means 50 years ago, we have done this thing, and still the success rate to decrease this one is only 50%. That means there is something which is not done by us properly. So there is a gap in this thing, and that is the reason why it is so important. We have to understand that. Globally, there are about 160,000 prenatal deaths and about 100,000 cases of disability annually. That represents not only the 50% reduction is only done by these more than 80 years, only we have done 50% reduction. We should have done much better. Ladies and gentlemen, in this preventive strategy, there are three strategies. The age-old, the postpartum NTD prophylaxis. The subsequently came the routine antepartum anti-D prophylaxis. And there are some special situations where the anti-D prophylaxis has to be given. So this is where we are being taught in our medical college day and been emphasized in our PGI days, where we used to give the postpartum anti-D prophylaxis to a mother who is Rh negative, has got baby delivered, we have done the blood group testing and she is Rh positive and the DCT is negative, and we used to give the 300 microgram NTD within 72 hours. That's a story in those days. And this level of 300 microgram was quite okay to neutralize about 30 ml of Rh positive fetal blood. So that has reduced the postpartum, the immunization has reduced the immunization to about 1.5%. So there is a substantial reduction by only giving postpartum the immunoglobulin or immunoprophylaxis. So later on we realized that there is a need, there is some failure is there. So there are one important thing in the postpartum. If somebody has got higher amount of fetal-maternal hemorrhage, then somebody can go for the rosette test or somebody can go for the clear Beck test to identify the need of more prophylaxis. In some areas and some areas in the world, they give double prophylaxis, means 2 doses, that means 300 and 300. In case of cesarean section, estimating there is or expecting or suspecting there is a higher rate of fetal-maternal hemorrhage. But wherever you suspect there is a greater fetal-maternal hemorrhage, we can do clear Beck test, and that will give you a calculation to how much amount of prophylaxis has to be given. But unfortunately, this test is not very commonly practiced or not commonly available. I'll ask our esteemed other speakers to throw a light that where and which test and which laboratory it has been done, but it is not usually done. Sometimes many of us as clinicians give the double dose when we are suspecting rather than going for clear Beck test. So with this thing, we have achieved something. Then in 1980s came the antepartum NTD prophylaxis, and that one is for asymptomatic women. So in asymptomatic women, we started giving around 28 weeks, and this was practiced to reduce further reduction of the sensitization. And there is a divide and when to give. In US, if you see the guidelines, they practice the 28 weeks. So what they do, at 28 weeks, they do the indirect comb test. If it is negative, then give 300 microgram NTD. But UK prefers 2 doses. One is 28 weeks, and then another one between 32 and 34 weeks. But at the current moment, I think if you look at the NICE and other guidelines, that yes, the routine antenatal administration of NTD prophylaxis has reduced this thing to further to about 0.5%. So there is a great deal of success. But ladies and gentlemen, if we look at the practice, in this area, we are still lacking in clinical practice because many of us forget or sometimes don't believe it, or sometimes by just going through this thing, the mistake happens in antenatal routine prophylaxis. So we have to be very careful in this group to improve our uptake and to prevent sensitization. There are areas, and there is a meta-analysis which shows that double dose versus single dose. And at the current moment, I think the most of the guidelines suggest that single dose of 300 at 28 weeks is probably enough. And that is the one at the current moment should be practiced. So, but again, I emphasize this is the area where we are probably not being consistent in our clinical practice. So I'll request all of us to remind ourselves and everybody that this is the need of the hour. The special situations are very important. But we have to understand that chance of Rh isomerization below 10 weeks is very extremely low. But at the same time, if it is more than 10, 12, 10 weeks, most of the people will recommend to give at least, if not full dose, you can give the half dose. It is available in our country, about 150. But if we go for the other things, that if we go for surgical management of the miscarriage, or if it is more than 10 weeks, probably it is better, or it is recommended to give it. If you don't give it, probably it will not be the right thing to do. In case of ectopic, yes. In case of gestational topoplastic disease, yes. In case of invasive perinatal diagnostic like Korean villus sampling and amniocentesis, yes, we give it, because these are the procedures mostly done by the fetal medicine specialist, and they are very conscious and very careful about this anti-D prophylaxis, and the mistakes in this group are or is very, very less. In externally cephalic version, whatever the outcome is, it is not much practiced, but in some countries, it is still practiced, and probably it is a good idea and recommended to have this thing given in the antenatal period. Needless to say, in case of placenta previa or abruption, that means bleeding after 20 weeks, it is to be given. But these are the areas, the special situations, they are all given. Most of the time it is given. The lack is, or the omission is not that common. The most common omission is routine asymptomatic prophylaxis at 28 weeks. With this thing, if we look forward towards the future of this thing, that where we are leading towards, there are two areas we are leading to. One is reminding us about the practice itself. So the practice change, particularly in the routine 28 weeks and the immunoprophylaxis. And the second important thing is the future direction is the cell-free DNA. Ladies and gentlemen, we know that this one particular thing which has come in the later part of the last century or the beginning of this century is changing fetal medicine in a very, very important way. We all know these are not fetal cells. These are the cell-free DNA are basically the apoptic cells, topoplastic cells, and these are changing the direction of fetal Rh genotyping. Also many other things, including the trisomy screening. So that part is going to change subsequently. At the current moment, these are commercially available in our country. The only question is cost. Ladies and gentlemen, we all know that to determine the fetal Rh status, it is about 99% sensitive, and the specificity is about 95%. But the important thing is cost effectiveness. Many European countries is now routinely adapting this NIPT. But at the current moment, even many developed countries and in our country also, this is being one of the factor is cost, where this is still not cost effective method, but time will say that gradually when the cost will be reduced, most likely this will be the one method which will change the scenario and will select where it should be given and where it should not be given. So with this thing, we have to understand the last part, that why there is a failure, why we have not been reducing this thing and only being successful in 50% of the cases. This is because many areas there are insufficient supply. Needless to say, but we have inquired their cost consideration, although the most of the preparation available in India are between 1,500 to 2,000 rupees. So, but still that can be costly for some. There are ignorance, particularly the caregiver, simply to forget the administration of anti-D, not only in the postpartum period, but also in the antepartum period. Lack of access, yes, that is another important aspect. And there are areas where the products are not being tested. Probably that is not applicable to India that much, but it can be ruled out. So what we conclude from this, that we are practicing postpartum immunoprophylaxis probably well, and that is mostly given. But if there is a omission, we have to still cautious, still instruct our juniors that and check, not instruct, that check, yes, they have tested the blood group of the baby, they have done the DCT, they have checked the hemoglobin and the bilirubin level, and if it is Rh positive, they have already given it and written down in the notes. About the, as I mentioned before, again and again, the routine antenatal anti-D prophylaxis has to be emphasized and kept in our mind and in our juniors and anybody in the team, that please remind us that this is a very important area we sometimes miss. Special situations, I have already mentioned about the miscarriage, ectopic pregnancy, molar pregnancy, invasive procedures, APH, the ECV, even in fetal death, yes, it should be given. In case of blunt abdominal trauma, yes, it should be given. There are sometimes there is a question, if you are doing a cesarean section and have done tubal ligation, whether it should be given or not. The answer is yes, it should be given for two purposes. One, there is a small chance of failure of sterilization, number one. And number two, subsequently she can have blood transfusion. And that is one of the reasons it should be given. So, ladies and gentlemen, it is very, very important to know that we have got knowledge. So lastly, I want to conclude by saying one of my favorite writers' quotation, that knowledge is of no value unless you put into practice, and is none other than one of my favorite authors. And thank you very much for patient hearing. Thank you very much.
Thank you, sir.
Thank you.
That was a very lucid talk.
There is a question from Dr. Deepti Sharma. Is prophylactic anti-D at 28 weeks recommended in a primipara also?
Obviously, that
would
is,
Dr. Barik please take this question?
Obviously, that is an important thing to give. Yeah, in primipara, that is the thing to give. That's the reason why it is given at 28 weeks. So yes, the answer is yes.
There is another question from Dr. Tamkeen Khan. What dose is needed in the twins?
There is no control trial in this area. Interesting question, Professor Tamkeen. Interesting question. There is no obvious trial is there, but the recommendation is still the same, that you give the same dose, 300 microgram. And if you are believing in the antepartum one, give 300. If you're believing in the two doses, then 300 at 28 weeks and 300 at 34 weeks. So that
Thank you, Doctor. There is a question from Dr. Neelam Jain. Is anti-D recommended in complete molar pregnancy?
Yes, there was a big debate about this area, that complete mole doesn't have any fetal component. So whether we should give or not, but it is a retrospective diagnosis sometimes, and that's the reason why it is difficult to differentiate between complete mole and the other hydropic generation or the partial mole. And the recommendation is at the current moment, yes, you should give it.
Okay. What are the situations where the dose should be more than 300 micrograms? This is a question from Dr. Mandakini Pradhan.
I've already mentioned that there are areas where you suspect the higher risk of fetal-maternal hemorrhage. There are countries where after cesarean section, they give it more doses, double doses, like Czech Republic and other places. In some of the European countries. But in our country, or many other European countries also practice where they suspect, they give it, or where they suspect greater amount of fetal-maternal hemorrhage, then do the clear bed kit test if it is available in your lab and calculate the dose and give it accordingly.
Thank you.
Thank you.
Please share your experience where anti-D was given, but the woman became sensitized. This is a question from Dr. Tamkeen Khan.
In this way, it is very difficult to tell because most of us deal with this thing, and not because the 5% incidence of Rh negativity in our country, it is not that much seen, failure is not that much seen in our country. But obviously in a larger series, I think Vatsala will be able to throw light on that because she has got a larger series. I request.
Dr. Vatsala, can you please take this question?
Yeah, I would be sharing our experience when I just talk in the end. So we analyzed around 200 cases when we found that a big number of women, even after receiving anti-D, do become isoimmunized.
Okay.
So I don't know, it could be because the fetal hemorrhage was underestimated, they didn't receive the anti-D in the antepartum period, or it could be just storage problem. We don't know if you're really following the cold chain or not.
Okay.
Thank you.
So we move on to the next talk, which is management of Rh alloimmunization in pregnancy. And I would like to invite our next speaker, Dr. Manisha Madhai Beck. She's a professor and head fetal medicine unit, CMC Vellore. She's a peer reviewer of Jogi FMF UK certification. And she has publications in index publications in national and international journals and chapters in books.
Thank you so much for giving me this opportunity to be talking about management of Rh isoimmunization. So my work has been made half easy by the former speaker, as Dr. Barik has very clearly outlined about why prevention is better than cure, especially with respect to this medical condition. So I'll be briefly talking about the following contents and try to make it as concise as possible. So we start about why does this happen? So as we've already talked about Rh incompatibility, where the male partner is rhesus positive and the mother is rhesus negative. So there is a rhesus conflict in these cases. And as Dr. Mandakini has very promptly told us that in India, almost about 5% of our populations are kind of Rh negative. And when they become pregnant, we need to take care of these women. So we have learned from our postgraduate textbooks that when you have a father who is homozygous, that means both the alleles have the capital D antigen, the gene for the capital D antigen, then all the progenies of that couple will be Rh positive. So there is 100% chance of rhesus alloimmunization. Whereas if the father is only heterozygous, that means only one of the alleles has the capital D gene, then 50% of the babies will be affected. So 50% of the babies will be affected. Now in our country, we generally don't get to do the genotype if the father is positive. So what we know from information is 35% of our fathers are homozygous, whereas 65% are heterozygous. So without doing the genotype also, if the father is Rh positive, then the chances that the odds of the fetus being Rh positive in an Rh incompatible couple will be around 67.5. Now, how does this happen? So there are three prerequisites that are required. First is that rhesus positive fetal RBCs should be there. Mother should be rhesus negative so that the mother RBCs do not have the D antigen. Second is that the mother should be able to launch an immunogenic capacity. She should have an immunogenic capacity so that she can produce antibodies against that D. And third is that there should be mixing of the fetal and the maternal blood to be able to initiate the whole cascade. Next slide, please. So fetal-maternal risk has very elaborately been talked about by Dr. Barik. What are the risk factors? So we have threatened miscarriage, ectopic, any prenatal invasive procedures, any fetal procedures like ECV, manual removal of placenta. But the maximum risk of a fetal-maternal hemorrhage happens at the time of delivery, whether it is a post-normal vaginal delivery or a post-LSCS. Next slide, please. So when we talk about feto-maternal hemorrhage, most of the cases have hemorrhage which is less than 3 ml. But there are a few pregnancies where you can have significant feto-maternal hemorrhage, and that is around 0.3% of the pregnancies. So it is these pregnancies with significant feto-maternal hemorrhage where your routine dose of postpartum prophylaxis is not likely to work. And I will be talking about these conditions briefly. So as we talked about the pathophysiology, so one thing that is important to remember is that the fetal RBCs, they do not contain the D antigen. So they are D negative, whereas the maternal RBCs are D positive. The maternal red blood cells are D negative, whereas the fetal RBCs are D positive. Now, if there is mixing of some if there is a feto-maternal hemorrhage, these D positive fetal RBCs, they enter into the maternal circulation. Now, when they enter into the maternal circulation, the maternal immune system produces antibodies, and that antibodies, if they are of the IgM type, they generally do not cross. But if they are of the IgG type, they cross the placenta and they start destroying the D positive fetal red blood cells and thereby causing the whole process. Next slide, please. So what is the natural history of alloimmunization? Next slide. So in the first incompatible, so whenever you have an incompatible, whenever you have a Rh positive negative couple, in the first pregnancy, what happens is the antibodies that are produced are IgM, and because they are large enough, they cannot cross the placenta, and therefore, usually the first pregnancy is protected. Moreover, as we said, that the maximum chance of feto-maternal hemorrhage is at the time of delivery. So that is taken care of by giving anti-D. If that is not done, then second pregnancy is at danger. Now, when we have second incompatible pregnancy, there is an amnestic response. So the immune system has already been primed to the D antigen. Now it produces a response which is much more vigorous. And this time you have IgG produced. Now, these are small and they are able to cross the placenta. Once they are able to cross the placenta, they will enter into the fetal circulation and result in the destruction of fetal RBCs. Next slide, please. So this is the pathophysiology of how hemolytic disease of fetus and newborn occurs. So because of the rhesus alloimmunization, you have maternal IgG produced, which starts entering into the fetal circulation and starts the process of hemolysis. Now, this hemolysis can lead to two things. It can lead to fetal anemia and it leads to hyperbilirubinemia. Now, fetal anemia, if it is severe, then it can result in fetal hydrops. Anemia, again, the hemolysis is of two types. You can have either extravascular destruction of the RBCs in places such as liver and spleen. So often we will find that these babies have hepatosplenomegaly. Or we can have intravascular destruction. And what happens is that the combination of two leads to fetal anemia. Now, if we have, if the compensation is there by increased erythropoiesis, if the bone marrow is competent enough, then it can compensate by increasing the erythropoiesis. But if for some reason that doesn't happen and the degree of anemia far exceeds the production by erythropoiesis, then it manifests clinically. Now, what happens to the hyperbilirubinemia bit? This bilirubin, which is produced because of the destruction of RBCs, it enters maternal circulation. When it enters maternal circulation, the mother is able to conjugate, and this conjugated bilirubin is excreted by placenta. So hyperbilirubinemia is not an issue when the fetus is in utero, but it becomes an issue once the baby comes out, because then the baby is not able to conjugate such large amount of bilirubin, and therefore we often tend to see manifestations in the form of kernicterus and other things. Next slide, please. So we were talking about natural history. We generally said that the first pregnancy is protected. Now, what are the conditions where the first pregnancy is not protected? There are two conditions. One is if the woman has already been sensitized because of a blood transfusion that was given prior to pregnancy and now she is pregnant. So in that condition, even her first pregnancy will not be protected. Second is the grandmother theory. Supposing the mother was Rh negative, but her mother was Rh positive, and she was exposed to those Rh positive cells in utero. So that can lead to sensitization even in the first pregnancy. So those two are the exceptions to the natural history of alloimmunization. Next slide, please. Okay. Now this I will just skip because this has already been spoken about by Dr. Barik. So anti-D, just the brief numbers. Rh Isoimmunization has been brought down by 16% to 1% following postpartum prophylaxis. Even more. because of the addition of anti-D given antepartum at around 28 weeks. Some of the countries give it at 34 weeks also to take care of any antepartum feto-maternal hemorrhage that would have taken place. Next slide, please. This I am going to skip. Again, this has been elaborately talked about by Dr. Barik. Okay, now what I'm going to emphasize upon is what are the causes of alloimmunization despite administration of anti-D. Now, the most common cause that we still come across is where the woman was not recognized as Rh negative and therefore was not given anti-D even if the baby was positive. But in places, most of the places have anti-D now, and therefore, in spite of that, why the woman presents with alloimmunization in the subsequent pregnancies. Next slide, please. So one is improper storage. So if you have a cold chain failure, then even if we give anti-D, then it is likely to fail. It is not likely to work. Second is inadequate doses. We were talking about severe feto-maternal hemorrhage where the volume is more than 30 ml. We know that your standard RhoGAM is able to neutralize around 30 ml. So if you have conditions, for example, in intrauterine demise, or if there is multiple gestation, or if there is abruption, these are the conditions which are usually associated with massive feto-maternal hemorrhage, and your standard anti-D doses will not be able to neutralize so much of blood. Then the rhesus system is made up of not only D antigens, it is also made up of C and E antigens. And if you're not able to recognize this, that is another cause of Rh Isoimmunization and inadvertent transfusion of rhesus positive blood. Next slide, please. Okay, so having talked about causes of alloimmunization, now how do you manage a pregnancy if there has been previous history of mild hemolytic disease of the fetus and the newborn? Next slide. So if there is previous history of mild HDFN, we usually do what is known as indirect Coombs test. Now in this Coombs test, we know that the maternal serum, which contains the IgG antibodies, is incubated with RBCs, which are D positive. And there is a binding of the immunoglobulins to the D antigen. Then we incubate it further with anti-Ds against the IgG. And what happens is all these cause the agglutination. And this ICT is done. And if it is positive, then we look for the titers at what titer agglutination is happening. And the more diluted it is and the titers are high, then it is more significant. So in a patient who has had mild affection, we monitor with ICT every 2 to 4 weeks. If ICT is positive, we check for titers. There is something known as a critical titer, which is important for us to understand. So it is the titer below which the risk of hemolytic disease of fetus and the newborn is unlikely, and hence fetal testing or monitoring is not required. Now this varies from lab to lab. Most of the labs usually take 1 in 16 as a critical titer. So if your titer crosses 1 in 16, for example, 1 in 32 or 1 in 64, then you need to act upon that, because then the risk of fetal anemia is high and you need to start monitoring them. Next slide, please. Yeah, so this is what I was talking about. If the ICT is positive, you check for the titers. If it crosses the critical titer, then we need to start monitoring for fetal anemia or via MCA Dopplers on the ultrasound. Next slide. Okay. Now, if in the previous pregnancy, if there was history of severe hemolytic disease, then these pregnancies are managed differently. Next slide. So when we talk about severe hemolytic disease, what we are talking about, for example, if there was previous history of a hydropic stillbirth, or the baby required neonatal exchange transfusion, or if there was history of intrauterine transfusion in the previous pregnancy, then all those would account for severe diseases. So in these cases, usually there is no role of monitoring with an ICT. So the monitoring straight away starts with monitoring for fetal anemia. And it is also important to know that at what gestation this fetus got affected, because roughly in the subsequent pregnancies, what happens is that the next pregnancy is likely to be affected roughly 10 weeks before what was the gestational age at previous affection. So for example, if the baby required IU2 at 32 weeks, then in the subsequent pregnancy, it's very likely that it will require somewhere in the mid-trimester. Next slide. Okay, so what is the aim of monitoring such pregnancies? The aim of monitoring such pregnancies is to detect fetal anemia before the onset of fetal hydrops. And you either, if the baby is reached the period of delivery, then you deliver the baby, or if the baby is still preterm, then you give intrauterine transfusion. It is important to know that there is no role of monitoring with an ICT in an alloimmunized pregnancy. Next slide, please. Okay, so there are different kinds of methods. We have the non-invasive methods, which are the most commonly used, and we have the invasive methods, which are obsolete. So non-invasive methods, including use of fetal ultrasound and looking for middle cerebral artery peak systolic velocity. Now, previously, how the whole thing started was by Liley using the amniocentesis and the amniotic fluid delta OD 450 to check for the amount of bilirubin in the amniotic fluid. But it was invasive and therefore it is not being used now. Next slide. So this was a study which is a historic landmark study which was published in the NEGM in 2006, and they found out that the invasive methods were much more efficient than your non-invasive methods were much more efficient than your invasive methods. So doing an MCA PSV was found to be more sensitive, more specific, and overall accuracy was much higher. And this was a prospective international multicentric study which included 165 women. Next slide. So how do we do the middle cerebral artery peak systolic velocity? Next slide, please. So in an alloimmunized pregnancy, we start, the earliest we can start doing it by 16 to 18 weeks. And we continue up to 35 weeks. After 35 weeks, the false positive rate with MCA PSV is slightly higher. Now, how does fetal anemia affect MCA PSV? Now, when there is fetal anemia, there is decreased in the blood viscosity. So the blood becomes thinner. Now, because of that, there is hyperdynamic circulation, and therefore there is increased flow through the MCA. So the middle cerebral artery peak systolic velocity rises. So if we have on ultrasound MCA PSV value, which is more than 1.5 multiples of median for that particular gestational age, then it is 95% predictive of moderate to severe anemia in the baby. Next slide, please. Okay, so a brief thing about the technique, because this is the main thing for monitoring in alloimmunization. So we take the transverse axial view of the fetal head, start with the BPD, and then we move caudally till we image the circle of Willis on color Doppler. And then the MCA is interrogated just off the origin of internal carotid artery. And we use the proximal, the MCA, the middle cerebral artery, which is closer to the ultrasound probe, is the one which is interrogated. And the angle of insonation, that is the angle between the blood flow and the ultrasound beam, should be 0. Next slide. So on top hand corner, you can see the circle of Willis being interrogated using a color Doppler, and the Doppler gate, which is placed in the middle cerebral artery, and the PSV is measured. Now, in order for us to get an accurate value, there are certain prerequisites. Next slide, please. So there should be fetal quiescence. If the baby is moving too much, then it's unlikely that we will get an accurate value. Usually 3 values are recorded, and the highest value is plotted on what is known as the Maris curve, which is basically MCA PSV plotted against the gestational age. Now, usually a rising trend is more significant rather than a single value and should be used for decision making. Now, oftentimes in clinical practice, if we don't have access to the Maris curve, a rough rule of the thumb is that if you have an MCA PSV, which is greater than equal to twice the gestational age in weeks, then it is very likely the fetus is affected. Next slide, please. So this is the Maris curve. You can see on the x-axis the gestational age in weeks, and on the y-axis you can see the MCA peak systolic velocity. Now, any value of peak systolic velocity which is above the curve A, those are the babies who require immediate transfusion if we can't deliver them. Second, if they are above the B zone, then we just need to repeat it between 5 to 7 days, and so on and so forth. Next slide, please. Okay, a word about fetal hydrops. Next slide, please. So fetal hydrops is basically the most severe form of hemolytic disease of the newborn. So what are the features? Here, usually the fetus has severe anemia. So usually the hemoglobin of the fetus, if we do a cord blood sampling, will be less than 5 grams per deciliter. There is evidence of extramedullary hematopoiesis. So usually there will be hepatosplenomegaly. There is evidence of heart failure and generalized edema. Next slide, please. So what are the ultrasound features when we diagnose fetal hydrops? We have a subcutaneous edema, which is usually more than 5 mm. Placentomegaly, usually in the late trimester, any value greater than equal to 5 centimeter, in the early greater than equal to 4 centimeter. Cord edema, presence of polyhydramnios, and fluid in at least 2 of the visceral cavities. It can be a combination of ascites, pleural, or pericardial effusion. Sometimes we've even seen scrotal edema and other things. Next slide, please. Yeah, so these are just a few ultrasound pictures. So in this panel, you can see on the left-hand side, you can see there's a halo around the transverse diameter of the baby's head, and that is subcutaneous edema. And on the right side, you can see that there is significant pleural effusion and again subcutaneous edema surrounding the thoracic cavity. Next slide, please. Here we can see image of the fetal liver on the transverse axial view of the abdomen, and that is surrounded by an anechoic black rim, and that is the fluid collection because of the hydrops. Next slide, please. Again, another appearance, the bat wing appearance of the lungs because of the presence of fluid in the pleural cavity. So we need to have fluid at least in 2 these things. Now, this is an algorithm that is very important for us to know for the management. So if you have mild, previous history of mild hemolytic disease of the newborn, we can manage with 4 weekly ICT till 20 weeks and thereafter doing fortnightly. If the critical titer is reached, and we said the critical titer is more than 1 in 16, then we have to do MCA PSV Doppler twice weekly. If we reach the abnormal MCA PSV Doppler, which is suggestive of fetal anemia, if the baby is more than 34 weeks, we deliver the lady. If the duration is less than 34 weeks, then we contemplate on doing the intrauterine transfusion. If on MCA PSV, if on ICT monitoring, we have a non-critical titer throughout the pregnancy, then we generally deliver them between 38 to 40. So this is the algorithm for the management of severe hemolytic disease of the newborn. So if you have severe hemolytic disease of the newborn, then there is no role of monitoring with ICT. We instead monitor with 2 weekly MCA PSV Dopplers, earliest being around 18 to 20 weeks. If the MCA PSV Doppler is showing signs of fetal anemia, that is the PSV values are more than 1.5 MOM. Again, we look at the gestational age. If the gestational age is more than 34 weeks, we tend to deliver. If the gestational age is less than 34 weeks, then we do give the steroids and we do the percutaneous umbilical blood sampling. IUT is done if the hematocrit of the baby is found to be less than 30. And after IUT, we generally wait for reassess in another 2 weeks time. And then based on that, again, if the baby is more than 34 weeks, we deliver. If the baby is still less than 34 weeks, then we go for a second round of IUT. Next slide, please. What time? Okay. So coming to intrauterine transfusion, this is all is going to be discussed. So I'm just going to give a brief overview, please. Next slide. Okay, so this is the gold standard for treating fetal anemia. If not treated, perinatal mortality in hydropic fetuses is around 60 to 70%. Next slide. So what are the indications if there's ultrasound evidence of hydrops? If our MCA PSV is greater than 1.5 MOM on ultrasound, and if there is evidence of fetal anemia on doing PUPs, that is fetal hematocrit of less than 30%. Next slide. There are 3 types basically: intraperitoneal, intravascular. I have highlighted it in red because it is the one that is preferred. So it can either be via umbilical vein or hepatic vein. And there is sometimes a combined approach where both intravascular and intraperitoneal are used. Next slide. So brief things about intraperitoneal. We generally don't use it as a first line method. It is used in combination with an IVT. It may have a role if our onset of disease is less than 20 weeks, but mostly it is used as a combination with IVT. If we are doing it for a hydropic fetus, the response can be very erratic, and one way to improve the response is by aspirating the ascitic fluid before we deposit the RBCs. Next slide, please. Intrahepatic, where you approach through the hepatic vein of the fetus. Now, again, this is done mostly. It has a role if the cord insertion is difficult to access, such as posterior placentae, And it has a role in twins because you want to be 100% sure that you are not transfusing one twin twice. So it has a role in twins. It is painful for the fetus, but for the operator, there is less damage due to needle displacement. Why? Because the tamponade effect of the liver prevents hemorrhage from occurring, massive hemorrhage from occurring. Next slide, please. So this is the preferred modality wherein the blood is given to the umbilical, through the umbilical vein, the blood is given. So the details of this will be dealt by the next speaker, so I'm not going to speak about it. One few things that it should be given in the umbilical vein instead of the umbilical artery, because in the umbilical artery, there's a greater risk of bradycardia. And usually the free loop of cord is avoided. And the point of insertion is where the umbilical cord is getting inserted into the placenta because the chances of needle displacement is lesser. Next slide, please. So this is a picture of how you can see that the cord getting inserted into the placenta and the needle going there for the transfer. Yeah. So following post-IUT, again, the rate of hemolysis is around 1 gram per deciliter. We must remember that it is higher in hydropic fetuses, and monitoring with MCA PSV might not be useful. So generally, we need to repeat in another 2 weeks' time if the baby is still less than 34 weeks. If they are more than 34 weeks, we tend to deliver. Next slide, please. So this is just a transfusionogram, which tells about the response. So the hemoglobin rises after IUT and then it falls. Next slide. Complications. Next slide, please. So predictors, there are 3 things that we need to remember. Predictors is if the pre-IUT fetal status, if the baby is hydropic, then the chances of success is less. Then gestational age at the time of first IUT, the earlier the gestation, the chances of success is less. And then the experience of the operator. Next slide, please. So we talk about the management of the hydropic newborn. If once the baby is, supposing the baby has got a suspected hemolytic disease, there are 2 components of the management. One is immediate labor room management and second is the neonatal management. Now the immediate labor room management depends whether the baby is hydropic or non-hydropic, because a hydropic baby requires advanced neonatal resuscitation. Baby needs to be intubated. And sometimes you might even have to do a paracentesis or thoracocentesis if the baby is severely hydropic. Next slide. What are the bloods that are sent for the baby? So the blood group, the direct Coombs test, the blood picture, total bilirubin and direct bilirubin. In case of severe hydrops, these are repeated every 6 to 8 hours, and hemoglobin, which is repeated every 24 hours. Next slide. So this is an algorithm about how a fetus with suspected hemolytic disease is managed. So there are 2 components of management. One is anemia and one is jaundice. Now, in terms of anemia, if the baby's hemoglobin is found to be 7 gram per deciliter, then partial exchange of transfusion is given around 20 ml per kg in the first 24 hours. If the hemoglobin is more than 7 gram per deciliter, then baby is just observed. The second component is jaundice. Now, jaundice for the guideline, management guidelines depend upon the NICE guidelines. If the baby is moderately jaundiced, then baby requires intensive phototherapy, that is the double surface phototherapy. If the baby is severely jaundiced, then baby requires exchange transfusion. If on intensive phototherapy there is no response, then the baby again will require exchange transfusion. Next slide. So the take-home messages of the talk are: there is no role of ICT in management of isoimmunized pregnancy. Monitoring requires MCA PSV 2 weekly starting from 16 to 18 weeks. And a value which is twice the gestational age is suggestive of fetal anemia. IUT is the gold standard for the treatment of choice. Next slide. Last IUT is done around 34 to 35 weeks and delivery by 36 to 37 weeks. And hydropic newborns require advanced neonatal resuscitation. Thank you so much for a patient listening.
Thank you, Dr. Manisha, for the very elaborate talk. Our next speaker is Professor S.C. Saha, and he's in the Department of Obs and Gynae, PGI Chandigarh. He's the Secretary of the Obstetrics and Gynecological Society of North India, and he's the in charge of the RBC Alloimmunization Clinic, and his special interests are fetal medicine, gynae oncology, minimal access surgery, including robotic surgery, and he has 70 international publications and various awards. Professor S.C. Saha, over to you, sir.
Thank you, Dr. Asna. Thank you. Very good evening to everybody. It's a topic I mean, I think it is quite interesting, and it should be, it's a good thing that you have given some importance to this important thing, important complication. Now, RH clinic in PGI was established in 1970. So when we were resident, it used to depend on amniocentesis for diagnosis of fetal anemia, and mostly they were intraperitoneal transfusion. In the later part, it became intravascular transfusion. Now, I became in charge of this clinic in 2006, and monitoring method had to change to MCPSB monitoring because of the reasons already told. And our main thing is intravascular transfusions in most of the patients, and sometimes intraperitoneal transfusions when intravascular transfusion is not feasible. Now, our experience of intrauterine transfusions are mostly in RHD alloimmunized pregnancies. In one case, only had anti-M alloimmunization. Now, these experiences have been published recently in Indian Journal of Obstetrics and Gynecology. We have also worked on non-invasive prenatal diagnosis in Rh Isoimmunization pregnancy, and that has been published in IJMR. Now, from 2006 to 2014, 363 women we found that alloimmunized, and out of them 44% required intrauterine transfusion, 23% were hydropic, and there are 464 transfusions. Now, 215 to 220 onwards, we haven't found any decrease in number of intrauterine transfusions. Each year, we get at least 40 to 45 women who require intrauterine transfusions, and we are roughly giving around, say, 150 transfusions per year. Now, this is a simple algorithm, what we do. So if it is first affected pregnancy, then IC titer has got its value, and the critical titer we take is 1 in 16 or more than that. And when it reaches there, we start MCPSB monitoring. Now, if patient has got already history of Rh affected pregnancy, then irrespective of titer, we start monitoring. And the monitoring we start at around 15 weeks. And we do it every 1 to 2 weeks. Whenever MCPSB is more than 1.5, we suspect there is fetal anemia. Now, what we do is we give intrauterine transfusion till 35 weeks plus. So if it is less than that, we give transfusion. If she is approaching 36 weeks or more than that, then we do deliver. Now, MCPSB monitoring will have to be quite competent, I think, and because it is a very important thing, and already it has been discussed that how it needs to be done. The MCPSB monitoring, the problem is that in spite of doing it everything correct, that in the quiescent stage, then there is a 12% chance of false positive result. So basically it means that for every 10 fetuses, you are giving unnecessary transfusions in 12. With its important consequences, both on mother as well as fetus. Now, one study was done by Hanif and Mariji et al., and they found that if you do it serially, and if you find the slope of this MCPSB, then probably it will be more predictive of anemia and less of false positivity test. We do it sometimes, particularly when you suspect that the fetus may not be anemic. So what we do is we repeat this MCPSB in maybe in 1 week time or few days time, and if it is persistently high, we go for transfusion. But if the patient has got history, particularly of previous stillbirth, or maybe they had some history of severe Rh Isoimmunization in the past, we do depend on MCPSB. Even if it is single value, we may repeat in 1 or 2 days and go for transfusion. Now, there are authorities, particularly to avoid false positive results. What do? They wait till appearance of mild hydrops. It is not that full-fledged ascites, generalized edema, just small amount of ascites or pericardial effusion, they give transfusion. And they have claimed that the success rate has not decreased. It is around 87% in this series. We do not believe in that. The reason is, what we have noticed is in the early pregnancy, the fetuses may be severely anemic without being hydropic. So we do not wait for hydrops. There is another reason, and we believe that in presence of hydrops, their ability, the fetus's ability to tolerate intratransfusion reduces. it has already been talked about. We take in our center packed cell volume less than 30 irrespective of gestation as indicative of severe anemia. Others have taken standard deviation below the mean. MOAS has taken -2 standard deviation below the mean to indicate severe anemia for the gestation. Sites of transfusions already has been told that mostly it is intravascular transfusion. We go into the vein, not in the artery, because the chances of bradycardia, or intrahepatic portion of umbilical vein, which we are using more often these days. Free loop, sometimes yes, but we try to avoid. Intracardiac is very, very rare. Intraperitoneal or combined transfusion, even nowadays, has got a place, particularly when the fetuses are affected very early in pregnancy. Now, we had to give intraperitoneal transfusions in some cases, and in both this, in these cases, it were mostly combined. Now, as because these transfusions are always, or most of the time, is below 20 weeks, the previous formula how to use the gestational age minus 20 does not work. So what has been, we have been found to be useful, and it has been already been found in literature that in 16 weeks, give around say 4 to 5 ml or maybe 6 ml. But if it's more than that, you increase by 1 ml every week. Now this has been recommended by Eoron et al, and it has been already been echoed by Moyes et al. Umbilical vein at placenta insertion is the most commonly used, but there is a problem, accidental cord arterial puncture and cord hematoma, and it seems the bradycardia are more in such cases. Intrahepatic, they are sure that it is keep going into the fetus. Incidence of fetal bradycardia is lesser, and even if there is a spillage of blood, it spills into the peritoneal cavity wherefrom it is absorbed later on. We prefer this route particularly in early gestation. Wherever we have got doubt that cord vein may be problematic, we go for intrahepatic vein, and we have found that this much safer option. You need to have a good team, but anyway, in teaching hospital, it may not be fixed, but it definitely helps, particularly in difficult intrauterine transfusions. You need to have a good ultrasound machine. You need to have autoanalyzer, which can give you results very quickly. Now, we do have autoanalyzer, but we have to share with transfusion medicine, but it requires frequent calibration, and that's a big problem. Sometimes it takes time to get the result. Equipments, we need a long needle, cheap needle, either 20 or 22 gauge, depending upon gestation, blood transfusion set, and 3-way cannula. And we always use fetal paralysis with becronium. NTG patch we used to use in the past for keeping the uterine quiescent during this procedure. Nowadays we have stopped it because it is not available. It is helpful, but anyway, its absence does not has not matter much. Blood component, it's the Buffy-Coat 4 saline washed, fresh, irradiated, and it should be HIV, hepatitis B surface antigen, and ACV negative. Now in the books we read that it should be CMV negative, but here we don't, because most of the patients are CMV positive. It should be compatible with maternal blood, O negative, and packed cell. Usually what you get is 70 to 80%, and that is what is recommended. How much blood amount to be given? We calculate for a simple formula, that is estimated fetal weight in gram into 0.02, and that will increase by 10%, the PCV. Now that is true provided the packed cell volume of the donor blood is around 70 to 75%. The target PCV, I have written 45 to 50, but not necessarily so. In earlier gestation, we target 40. In high drops, as because they cannot tolerate so much of blood right in the beginning, our target is 25 to 30. And later on, after 3 days, we increase to around say 40 to 45%. Sometimes it can go up to 50, but that is not a target. We go 40, 45%. There are other methods also available to check that how much blood to be given. And there is one formula here, which is uses the fetoplasmal volume and the initial or final hematocrit test of what is required, important. Technique, the patients, what we do here as a daycare case. informed consent is important because there can be fetal death during the procedure or after that. Steroid is always routine if we think that she may require delivery and the salvageable. So yes, at least once she should require, she will get steroid, particularly when doing around say 30 to 34 weeks of gestation. OD staff neonatologist to be briefed beforehand, particularly if you think that if there is any complication, she will deliver the fetus. We always check MCPSB, expected fetal weight, before starting the procedure. Choose the site of intrauterine transfusion again, because whatever you have chosen in the past may change because the baby moves. Sedation only if the mother is anxious, but in general, we do not use. Sterile field, sterile probe cover is very, very important, and you need to identify each and every medicine which is going to be used, and that is very, very important practically. Fetal paralysis, we always use. If you're going to the vein directly, given to the vein, vecuronium, or otherwise, if you are targeting intrahepatic portion of the vein, then vecuronium intramuscularly. Ultrasound guidance under freehand technique we use, and obviously check that the needle is inside, make sure it is there. Doppler helps to identify target. Particularly the first transfusion, you obtain samples for ABO, RH, hematocrit, mean corpuscular volume, obviously it helps, but after multiple transfusion doesn't matter. What will depend after multiple transfusions or after first transfusion, hematocrit and hemoglobin. Amount of blood to be given, I've already said, transfusion at a slow rate. In any case, you cannot give a lot of blood through that smaller, finer needle. Check fetal heart during procedure continuously, and that is very, very important. You not only check fetal heart, and if you're looking at the heart, you also look for the contractions. You must be watchful for the maternal supine hypotension. Usually you prefer left lateral, but sometimes patient is more comfortable on dorsal position. Check mid-transfusion and post-transfusion paxil volume and hemoglobin. Now, mid-transfusion particularly, I found that it is helpful in case of high drops, because whatever formula I have said, they may not work for this kind of patients. And mid-transfusion, by that, you know that, okay, this much I have given and this much is risen. So accordingly, you can change, you can select that how much amount of transfusion needs to be given. Post-transfusion monitoring, fetal monitoring is a must. And we discharge only when patient starts perceiving the fetal movement. And it takes around say 2 to 3 hours. If the patient is near term, then we prefer to keep overnight in the hospital. We do not use routine prophylactic antibiotic, but if there are multiple attempts, then we do, but that rarely happens. When we give the subsequent transfusion in high drops, after say 48 to 72 hours, sometimes we have given early also at 24 hours for the second transfusions. But afterwards, it depends on what is the paxil volume of the post-transfusion sample. Now, the calculations usually is the paxil volume falls 1% per day once fetal erythropoiesis is suppressed. And that takes, I would say, 3 or more transfusions. Hemoglobin drops by 0.4 to 0.3 gram percent. Our target is that paxil should not be less than 25. Hemoglobin should not be less than 7. We also do MCPSB, and we take cutoff more than 1.5. We do not go by more than 1.69, which has been recommended by certain authorities. Now, currently I found one control trial, randomized control trial, and what they've said that you can take either estimated hemoglobin or PCV, or you can use also MCPSB. Both are equally good. There are fallacies, no doubt. After multiple transfusions, the reliability of MCPSB decreases. So you have to obviously balance. Usually what you do is, even if MCPSB is normal, we don't tend to wait more than 3 to 4 weeks. Sometimes you have waited up to 3 to 4 weeks, that's okay. But usually we keep transfusion. Now, this is a small video of intrauterine transfusions at the cord. Now, we identify it Okay, under ultrasound guidance, we push the needle. Now, in our center, what you do is, okay, I tell my assistant to put the needle in, and thereafter near the target, I take control and go into the control. Right? Now, you need to be careful here because the arteries are there. We don't want to puncture the artery because that will cause problem. We don't want to go through this coronary plate also. That also is going to cause bleeding. So be sure that you're near the target and then you go in. Now here, initially we start with the fetal paralysis and then we give transfusion, whatever is required. We keep on monitoring. Now, what you can do is you can just take the fetal heart rate from cord arteries, which is nearby. You can just see all the pulsations and how much is it, and that gives a fairly good idea on how is it. Now, this is a video showing intrahepatic the transfusion at the intrahepatic portion. It was 29 weeks. So it is the posterior placenta, as you see here. Under ultrasound guidance, we just put the needle into the vein. So just adjust a needle and go inside. Right. Now, before proceeding with intrahepatic portion, you must do this fetal paralysis. And for that, usually we approach this either fetal thigh or buttock. We use 22 gauge spinal needle, and we give vecuronium at the dose of 0.1 milligram per kg body weight. Now, what happens if we do not use? That's a small video. I mean, I thought, okay, fine, it is fetal parts are very far away. There is a patient with high drops. We'll just go here, right? So once we touch, the baby moves. Anyway, I thought it is not going to be very difficult, so I just persisted. No, I'm not advocating this, but sometimes it does happen that even after giving fetal paralysis, baby moves. Okay, so now here, right, so a little bit of adjustment, just I want to make sure that it is inside the vein before removing the stellate. So what happens if you remove the stellate and then replace it in, some amount of air goes in and the visibility decrease goes because it becomes white. So I just wanted to be sure that I'm inside the vein, confirm with the aspiration, and then give vecuronium. But in this particular case, what happened is there's mix up with the medicines. So my assistant was late, and in the next video, you'll see what happens, right? The baby starts moving, and that's very dangerous because it causes damage to the liver. What you need to do is just don't keep this needle fixed, just leave it, let the baby move with this, okay, so that will cause less damage. Now, once you take out the needle, there will be a bleeding from here, but it remains here. The provided you have corrected the anemia, this blood will get absorbed later on. Complications, there's a large study by Van Kemp from Netherlands. And what they found, it's quite safe. The intrauterine infection is at 0.3%. Now, they also do not use any prophylactic antibiotic. Preterm premature rupture was 0.1%, and intrauterine fetal death occurred in 0.9%. Procedure-related complications was 3.1%. In our series, the procedure-related complications was 3.8%. IFD was 1.6%, but that is how we had defined. We had defined that any intrauterine fetal death which has occurred within 1 week, we have taken is as procedure related. Even if there was severe high drops, and in the most cases, it is not procedure related, but because of the fetal condition, the babies died. Severe bradycardia can be a problem and quite unexpected. Usually the management is do we stop transfusion, stop, right? And then put the patient in left lateral side, wait for some time, but sometimes if it persists, you may have to give atropine. In 1 or 2 patients, I have given adrenaline. There is no recommendations like that. I'm not suggesting it that you do it, but anyway, in desperate situations, we had to do it, and both the babies survived. Delivery, 37 to 38 weeks, gestation is preferred, but usually this 2 weeks after the last transfusion, cesarean sections only for fetal indications. The survival in our series, overall survival is 90%, but there are many reasons for that failures. High drops in 60 to 67%, but high drops survival rate depends on whether it's a mild or it is severe. In mild high drops, it is quite good. It is around 90%. Now, there are special situations like the severe alloimmunization, particularly early in pregnancy. And there are authorities who suggest that you do plasmapheresis, you give intravenous immunoglobulin. In our centers, we do not do it because most of the patients, they are very poor and they cannot afford it. And our department doesn't provide it also. So what we do is, we give intravascular transfusions at intrahepatic portion of hepatic vein. We use 22 gauge of T bundle. We give intravenous transfusions or combined transfusions if we cannot hit the hepatic vein, which hardly happens. Now, we did a small study.
Can everybody put themselves on mute? Please, everybody.
Sorry. Now, where
put yourself on mute.
22 fetuses require transfusion, and between 16 to 25 weeks, 22% were hydropic. The median number of transfusions were 4.5. 77% of transfusions were intrahepatic vein. There was technical difficulty in our 3.8% of cases, not cases, in the procedure. And survival rate was 86%. It was at par with intrauterine transfusion at later gestation. So I do not agree that gestation per se, obviously it makes it difficult. That reduces the success rate so much. Long-term outcome, now it has been touched upon by my previous speaker, but exchange transfusion almost 1/3 these days. In the past, it used to be around 70%, but now it is around 33% require exchange transfusion. Phototherapy, almost 80% or more than that do require. Drop of transfusions because of suppression of erythropoiesis, and in the first 3 months, they do require transfusions, and this is around 13% in a small series. Iron overload is there almost in all transfusion cases, particularly if they have received multiple transfusions, but whether it has got effect later on, we do not know. Thrombocytopenia less than 15%, 50,000 has been seen on 10% of neonates. Now, that I'm not sure that is because of intrauterine transfusions. There was a study recently from a neonatology unit, and they found thrombocytopenia even in those Rh Isoimmunization patients who have not required intrauterine transfusions. Prematurity still now is a big problem because of the side drops and others. Intraventricular hemorrhage and periventricular leukomalacia also has been found in a significant proportions, but they may or may not be related to intrauterine transfusions. Maternal, there are problems of multiple atypical antibodies, and that is around in 1/4, and that is a problem, particularly for transfusions or transfusions the next pregnancy. Neurodevelopmental delay outcome. Recently, we have studied in 30 neonates, and what we have done is we have taken general motor movement in around say 48 or 52 weeks of postmenstrual age, and we have found it abnormal in 3 out of 30 patients, that is 10%. One of them had severe hydrops, probably that was the cause. In other 2 had asphyxia and hyperbilirubinemia, but they did not require more than 2 transfusions. So, and they did had only mild to moderate anemia. So per se, intrauterine transfusions was not a cause, but what it signifies, but this cohort is at high risk, and here these neonates have to be later on followed up properly. Right. Anyway, I think Dr. Mandakini will summarize that. Thank you very much.
So You were talking about preventing stillbirth from Rh Isoimmunization. So we all have gone through the 3 talks, and we know that prevention is always better, and we have a very important tool, anti-D, to prevent Rh Isoimmunization. Still, if isoimmunization occurs, treatment is there, which is intrauterine transfusion, but we have seen that facilities are not available in all centers, requires intensive monitoring with ultrasound, middle cerebral artery peak systolic velocity, and intrauterine transfusion is also a very skilled procedure, is not available everywhere in all the centers. So we still have to focus on prevention. So it has been shown that when you look at the global picture, they, like the authors in this study, have made an estimate that 52,000 stillbirths every year occur because of Rhesus disease, 98,000 neonatal deaths, 67,000 cases of hyperbil, 17,000 kernicterus. There's a lot of neonatal morbidity and mortality because of Rhesus disease, and we seem to be contributing to a large number, because 3/4 of these deaths occur in sub-Saharan Africa and South Asia. And has already been talked by the speakers, in the absence of antenatal intervention in Rh isoimmunized pregnancy, 14% will end up in stillbirths. 30% will have severe disease, which would be fatal without treatment, that is intrauterine transfusion in a large number of cases. 30% have moderate disease or hyperbil. So 60% of the pregnancies which are Rh isoimmunized will have neonatal morbidity or mortality. 40% will be asymptomatic. So that is a lot of morbidity because of one disease per se. As far as India is concerned, worldwide, the burden of Rh hemolytic disease is 3.7 lakh cases per annum. And we contribute around 57,000 cases per year. So that is a big contribution we are making to this disease. In another paper by the same author say that 10 lakh Rh negative women are at risk of developing Rh isoimmunization in India. Although the chance of the incidence of prevalence of Rh negative status in women is 5%. Because of the sheer numbers that we have a whole lot of Rh negative women who become pregnant and are at a risk of isoimmunization. So of these 10 lakh women who may become pregnant every year, we are only using 2.5 lakh units of anti-D. So there is a big gap here, which is leading to Rh isoimmunization. So in this another paper, the authors have looked at the gap between the required dose of anti-D and what is actually administered. So if you look at Asia South, which we think is mainly the population is the Indian population, antenatal doses are around 19 lakhs, postpartum doses we need around 15 lakhs. So total we need around 35 lakh doses, but what is administered is around only 4 lakh doses. So there's a huge gap here. Overall, also worldwide, there is a gap, but it's only in the high income countries that there is no gap. So if you look at this chart, and the upper line shows the optimum threshold for giving anti-D, that is both antepartum and postpartum, and the lower threshold is only postpartum anti-D. So the high income countries are in a very comfortable zone here, but in most of the developing countries are below the minimum threshold, that is not even postpartum anti-D is covered. And Asia South, it is much, much below what is actually required. So this is an important factor contributing to the disease. So what is the way forward for us is that we should do blood group testing for all pregnant women. There's still a lot of pregnancies which occur and the blood groups are not tested. I think that is really criminal. Not only in pregnancy, I think we should sensitize all our women, teenage girls, that they should know their blood group, which is just like their identity or their name. Unavailability of anti-D or not using anti-D because we're not doing the blood group, so we don't know she is Rh negative, or we forget the antepartum dose or the postpartum dose. One has to be aware about all the sensitizing events. It's not only delivery and antepartum period, but as listed by the previous authors, there's a whole large number of sensitizing events. And if a woman has become sensitized, we should be able to see that she's sensitized. We should be able to have an indirect scoop test on her. And if we know that she's sensitized and the titers are above critical, she has to be referred to a fetal medicine center for timely management. One thing I would like to highlight is if you're giving anti-D, it is not going to protect against other minor group antigen, although it forms less than 1% of isoimmunized cases. And another thing, although we say anti-T should be given within 72 hours, but if you miss that time, don't hesitate to give it even within 14 days or even up to 28 days. It would have some protective effect. And the most important thing for achieving our goals is education and awareness. So a little bit about our experience. So this was 200 cases analyzed who had become Rh isoimmunized, managed in the unit. So almost half of them had not received any NTD after delivery or after MTP. It is very rare that they would have mismatched or Rh positive blood transfusion, and 24% we thought had got inadequate NTD. So how has the numbers changed? So this is our experience over the years of 2015 years. So we find that the number of cases that we are transfusing are increasing, and the number of women we see are also increasing every year. So we, over like 15 years, we have 389 women who have undergone more than 1,000 transfusions. And every year we are doing an increasing number of transfusions. So that does say that maybe we are detecting these isoimmunized pregnancies and referring, but that is not a very good thing. We should not be having so many Rh isoimmunized pregnancy. The only good trend we have seen is a decrease in the number of hydropic fetuses. So it's not very unusual for us to see these kind of women who are multigravida, 8-9 pregnancies with no living issue, multiple losses. And it is really short of a miracle that we do multiple transfusions and give them a live baby. So we have published a part of our experience in 2015. So our survival rate is very comparable. It is more than 90%, even hydropic fetuses. Recent data shows that our survival is almost 90%. Procedure-related complications are also comparable. So we have published a paper in which we have done 303 transfusions and 102 women, so on average 3 transfusions per woman. The complication rate per procedure or the fetal loss per procedure is also comparable to that published. So just to conclude, Rh isoimmunization is a very much a preventable disease with a very simple thing, just an injection anti-D. And the treatment of fetal anemia with intrauterine transfusion is also feasible and successful. So timely referral is important, and subsequent pregnancies tend to be more severely affected. So we need to prevent the disease and manage the first isoimmunized pregnancy better. Thank you.
Thank you.
Thank you so much, Dr. Vatsala, and in fact, everyone. What I'll do is I will go through my slides very quickly so that we can end up and have some time. So thank you, Society of our Stillbirth Society, to bring this topic. That's one of those topics that I dream of. Why is because, am I audible?
Yes, very nicely.
Okay.
You're very nice.
Thank you. So what I have done is my first 2 slides, this is 10th gravida, where Dr. Vatsala ended. That 10th gravida, none alive. She never thought that she will have a baby. She had already adopted a child and became pregnant previous to LSCS. She wanted a blanket for her husband when we wanted to admit her for a transfusion. This lady is now with the baby following 7 transfusion. This is another 12th gravida. When this patient was going on, another 12th gravida, non-alive, and also has got her baby on her hand after following 4 transfusion. So this is not credit to us. This is rather discredit to gynecologists. Those who had managed all these previous pregnancies and were responsible for making her obstetric history like that. And that was basically our aim of having prevention of stillbirth committee or a society of prevention of stillbirth. So to summarize how to approach for everyone Rh negative, please do not base your management on husband's blood group. Husband may not be equivalent to partner. So be careful of that. So get a mother's ICT at the first visit. So if it is negative, that is very well said by Dr. Barik, that you repeat your indirect Coombs test every 4 weekly, it continues to be negative. Or else, if you are in a setup that indirect Coombs test cannot be done, you do it at least at 28 weeks. give her an injection of anti-D that is called as an antenatal prophylaxis. Then deliver her at term, unless until otherwise she is complicated or something else goes on, but do not allow her to go post-term. So this is a patient who is non-isoimmunized. You have given antenatal prophylaxis and you are delivering at 40 weeks. Next comes is, this is a woman who has got ICT or indirect Coombs test, which is positive in her first visit. So, and you went ahead and do a critical titer analysis. So this critical titer, which depends on the lab, and mostly it is 1:16, few labs is 1:8. So you determine the titer. If the titer is less than critical, you continue doing indirect Coombs test 2 to 3 weekly. It continues to be less than critical till 38 weeks. You deliver at 38 weeks. Do not allow this pregnancy beyond 38 weeks. Of course, I'm ruling out all the rest of the pregnancy complication, but preferably in a center where there is facility for exchange transfusion to the baby. 50% of these babies may require exchange transfusion. It depends on the amount of anti-D, which we are not determining in India. Now comes the third situation. ICT is positive. It is more than critical titer, what Dr. Saha explained about it. And Dr. Vatsala nicely explained that, or there is history of high drops, or there is features of high drops. Previous history of high drops. Then in previous history of high drops, you know that this woman will be definitely isoimmunized or alloimmunized. So then what you do is you start monitoring with middle cerebral artery. Dr. Manisha very nicely said that how to do it. So you monitor this woman with middle cerebral artery. Here is another woman. See her face. 8th gravida, 2 alive. This is her eldest first pregnancy. And this is the pregnancy that had connecterous mental retardation in this baby. And rest were stillbirth. Came to us in emergency with high drops. Hemoglobin, hematocrit of the fetal hematocrit was 2.8, or else the hemoglobin was 0.8. Chances of survival 60%, 70% say use high drops. No, and whereas it would have been 95% in non-hydropic. Now, this woman received 6 intrauterine transfusion and baby received IVIG, had a normal delivery at 36 weeks, discharged from hospital. See this woman, she is all decked up for this photograph. Now, so you can imagine her before and then after delivery with the baby on her lap. So this is what we can change as an obstetrician. We can change this situation. This is a preventable disease. Let's join hand together to prevent this condition. We do not take pride in doing an intrauterine transfusion. But however, early diagnosis is possible, and by doing middle cerebral artery peak systolic velocity. Please remember that this is double the gestational age in weeks is an indication for referring the patient to the fetus to intrauterine transfusion. So take home message, that is what I have summarized. Rh negative pregnancy, ICT at first visit. Negative, you do antenatal and postnatal prophylaxis. If positive, then go ahead and do a titer 2 to 3 weekly and then deliver this woman at 36 to 38 weeks. If more than critical, then monitor with MCA PSV. And obstetric history suggests isoimmunization. In those patients, you start monitoring with MCA PSV. And if there is a sensitizing event, then you give immunoprophylaxis like bleeding PV or any CBS, amniocentesis. You do immunoprophylaxis, that is Dr. Barik nicely said. Preferably you give polyclonal in the hand, in the deltoid, and the dose is 300 microgram. Antenatal is 28 weeks. Postnatal, as Dr. Vatsala highlighted, that 72 hours. If forgotten, you can give up to 4 weeks. Here are two cases, that is 31 weeks, difficult case, twin pregnancy, and you can see that both the twins have got high drops. And this is the patient who has come on 24th. Today is 29th, 5 days back. So both the babies have got high drops and the intertwin membrane. MCA PSV 85, 92. We can prevent, we could have referred these patients earlier than this, that the obstetrician have done. Do not be too late. This is 4th January of this year. See the amount of high drops this woman, and this woman has come all the way from Orissa to Lucknow, taking a flight. And now she caught COVID. She caught with COVID. We monitored her and then had to have a transfusion. First transfusion we gave, then subsequently she had COVID, and subsequently we have given on 22nd on the second transfusion. So in this era of COVID, we need to be very, very careful and monitor these women, and preferably we refer them not to like this and not like this, at least this hydropic going up to high drops, and then referring the woman to a nearest center for intrauterine transfusion. We as an obstetrician must avoid having this condition. So let's join hands to prevent this. And we acknowledge all patients, all referring doctors, resident doctor, transfusion medicine and neonatology. That's this thing. Sometimes we have 3 women with 3 babies, all are receiving intrauterine transfusion. One woman who is expecting her delivery. So see her face. She is definitely sad that what will happen to her. Definitely intrauterine transfusion. Sometimes we discharge 2 women together, and some patient can see you in the AIIMS conference with the intrauterine transfusion baby in her hand. So this is what our experience is. I am sure all centers who are doing this transfusion have got similar experience like mine. We get pride. We feel very, very happy when we see these women coming with a live baby. But please remember, these are obstetricians who are responsible most of the cases. And now let us remember that even primigravida are not truly primigravida. They have undisclosed pregnancy beforehand, and the pregnancy that has brought her to our clinic is not exactly the first pregnancy. And this incidence is increasing. Probably the coming days, over-the-counter MTP pill has caused this. And we have got our analysis also shows this. So we need to be very, very careful in giving or monitoring these women with our MCA PSB. Thank you, Dr. Tamkin, Dr. Asna, and everyone. At least I thank Dr. Sukumar Barik, Dr. SC Saha, Dr. Vatsala, Dr. Manisha for taking out time and sharing their experience of huge data of these Rh Isoimmunization, and then making us aware and making everyone aware that this is a preventable condition. We must join hand to prevent this condition. Thank you so much.
Thank you. Thank you so much, Dr. Mandakini. There are 2 questions for you.
Yeah.
And there were previous 3 questions before your and Dr. Vatsala's talks. I think they must have got their answers in both your summaries. So there is a question for you, ma'am. Till how many weeks we can give prophylactic anti-D if the patient didn't receive earlier at 28 weeks?
Dr. Barik, do you want to take it up? You can give up to 34 weeks.
Yeah,
Okay.
basically, I agree that if he has not received at 28 weeks, till about 34 weeks is fine.
And if the patient comes at 36 weeks?
You still give it. If
Because-
ICT, provided ICT is negative.
Yeah.
Thank you. That is all, ma'am. I wholeheartedly thank all the esteemed and learned speakers of this webinar, Dr. Sukumar Barik, Dr. Manisha Madhai Beck, Dr. SC Saha, and Dr. Mandakini Pradhan for so graciously giving their precious time and valuable inputs to make this webinar a great success. I am also very grateful to Dr. Vatsala Dhadwal, our chairperson, for her gracious sharing of her vast and profound experience with Rh sensitized pregnancy. You so very nicely summarized it, ma'am. I'm also deeply grateful to Dr. Mandakini for her magnanimity in giving me the credit, which she equally deserves. She was the mentor and guide behind this webinar. I would fail in my duty if I do not thank our President, Dr. Neelam Aggarwal, Vice President, Dr. Nuzhat Aziz, and our Secretary, Dr. Tamkin Khan, for providing us with such a valuable learning platform. Surely we cannot thank them enough for the Stillbirth Society of India. And last but not the least, a very big thank you to our respected audience for patiently hearing this webinar, which I'm sure has been a great learning experience. Thank you very much and have a nice evening. Thank you.
Thank you so much, Dr. Barik, Dr. Dhadwal. I know you all are so busy, Dr. Saha, Dr. Mandakini, and Dr. Nani for arranging this. Thank you so much.
Ma'am. It was a pleasure.
Yeah.
Okay.
Thank you. Thank you for the invite. Thank you so much.
Thank
Thank
you.
you for inviting, actually. Thank you.
Yeah.